So then our last area to look at for drugs affecting the cardiovascular system is in congestive cardiac failure, also known as congestive heart failure. So this is where the heart is not able to maintain circulation sufficiently. It's become weak, and so it is not able to keep up with the keeping the blood flowing as much as it should be. You get poor circulation and you get congestion of blood behind the heart. In left-sided heart failure, which typically results from things like hypertension, heart attacks and atherosclerosis as a very late symptom to having these long term, so the left-sided is more common, and you can't keep up with pumping blood into the systemic circulation, so it congests back into the lungs that we can see depicted around the heart here. And that extra blood in the lungs leads to things like coughing, shortness of breath and fatigue. If that continues for a long time, you can then also end up with right-sided heart failure. And in right-sided heart failure, you're not getting enough blood through the right side of the heart into the lungs, not being able to pump against that congestion in the lungs. And so then blood also backs up in the systemic venous system. And that's going to cause things like swelling of the legs, feet, ankles, sometimes around your abdomen and so on. So you're not getting sufficient circulation, you're getting all this backing up of blood. So these days it's mostly treated by trying to reduce the work the heart has to do by lowering blood pressure and fluid load with things like ACE inhibitors and diuretics. But there's also been a long history of use of cardiac glycosides, and they're still used occasionally in congestive cardiac failure, and particularly in certain cardiac arrhythmias, like the quite common atrial fibrillation that happens quite commonly in the elderly. So digoxin is a cardiac glycoside, that's our drug class. It's a derivative of digitalis or foxglove. And it works by acting on sodium-potassium pumps in the heart muscle. So we know these sodium-potassium pumps pretty well. They're found on cells all around the body, but we're looking here particularly at the effect of cardiac glycosides on the sodium-potassium pumps in cardiac muscle cells. So the sodium-potassium pumps pump sodium out of the cell and potassium into the cell, and that sets up the concentration gradients for things like action potentials to occur. And inhibiting these means you keep the cell slightly depolarized. You also affect a sodium-calcium exchanger, again keeping more sodium in the cell and the cell slightly depolarized, meaning more calcium will enter through voltage-gated calcium channels and more calcium will be released from the sarcoplasmic reticulum. More calcium in the muscle cell, the cardiac muscle cell, means stronger contraction. More forceful contractions of the heart is going to help to relieve heart failure and also promote the transmission of the cardiac action potential, helping to relieve certain arrhythmias. So the digoxin has a long history of use in heart failure, but isn't generally a first-line drug today, mostly because of its potential for toxicity. So it has the potential to induce fatal cardiac arrhythmias, and this is combined with the fact that it has a very narrow therapeutic index, so you have to get the dosage right. It comes with lots of drug interactions, particularly from the fact that it's a substrate of P-glycoproteins, membrane proteins along the gut we mentioned way back in pharmacokinetics near the start of the semester. These can change the absorption of different drugs by trying to pump them back out again at the gut. And lots of different drugs will interact for these P-glycoproteins, and so the level of absorption will depend on what else you're taking. Also, the level of activity will depend on the level of ions in the body. So anything like hypokalemia, hypercalcemia, hypomagnesemia, differences of potassium, calcium or magnesium levels in the body, and particularly diminished renal function, which can in turn affect electrolyte balance in the body. All of these contribute to increased risk of digoxin toxicity. So that's a major part of why it's fallen out of favour, because of the risks associated with it. So shouldn't be used if there's any hypersensitivity to the digitalis plants that it's derived from. Things like ventricular fibrillation, where you're not getting normal passage of cardiac action potentials from one cell to the next. Lots of things might decrease its absorption, and then a number of drugs will interact, many drugs will interact with it. We've mentioned it often as a drug interaction for lots of the other drugs we've covered, and also a number of herbs may interact with it to increase its toxicity, things like ginseng and ephedra. So then we need to move on into our last area, drugs affecting the respiratory system. In particular, we're focusing on drugs for asthma. So asthma is a condition where you get a hyperreactivity of the airways, often to allergens. So in allergy-induced asthma, what you're getting is antigens or allergens entering the airway and then being able to bind to IgE antibodies that have attached to mast cells lining the airway. This binding of the antigen to the mast cell antibodies leads to a degranulation of those mast cells. That is, they release a whole lot of inflammatory mediators. And those inflammatory mediators cause the normal airway with its nice, relatively wide lumen and narrow wall to alter so that the wall becomes swollen. You get a bronchial edema. It overproduces a viscous mucus that continues to narrow the airway further, and you get a bronchoconstriction, a constriction or contraction of the smooth muscle lining the airways, so that you end up with these very narrow, inflamed airways. That means that you get much less air passage through, much greater airway resistance, air trapping in the lungs, significant shortness of breath, potentially to the point that there isn't enough gas exchange going on and it can be fatal. And so the treatment of asthma relies on two key aspects: relievers of acute attacks and preventers of attacks. So relievers are about symptomatic relief, getting the airways open, allowing gas exchange to resume at normal or near normal levels. Those inflammatory mediators, though, are going to be able to cause damage over time. The chronic inflammation will cause damage in the lungs over time, plus every asthma attack is a risk, and there's always potential for fatal attacks to occur. So you want to limit the number of attacks, to limit fatality, and also to limit cumulative inflammatory damage and fibrosis occurring within the lungs. So you usually use a combination of treatments. In just very mild cases of asthma, you might use just relievers, but if people are using their relievers often, they should also be on some sort of preventer that's going to minimise the severity of symptoms, prevent attacks, and that's going to be targeting the immune response, in targeting the inflammatory mediators that are actually causing the asthma attack. So this is going to involve bronchodilators or relaxants for relief of acute attack, and immune modulators or immune suppressors for preventers mostly, and occasionally mast cell stabilisers as preventers as well. So the drug therapies for asthma are pretty varied. It's often a lifelong condition, so there has to be, adaptability to different individual patients' needs. There is then therefore a lot of options, and there is all these different combinations of relievers and preventers, sometimes in formulated combinations. We also have something that sits a little bit in between the two, what we call the controllers. These act in the same way as the relievers through bronchodilation, but they're not for acute attacks. So we're going to mention a lot of the drugs that are covered on this slide here. So first of all, those for relieving acute attacks, that is, those that act in causing bronchodilation or bronchorelaxation. Those are just about getting the airways open. These don't target the actual inflammation, but instead look to interact with the signalling that normally controls how constricted or dilated the airways are. And this is the signalling that normally controls that is our autonomic nervous system. So our sympathetic nervous system uses noradrenaline and adrenaline to trigger bronchodilation, getting the airways open. Our parasympathetic nervous system normally causes bronchoconstriction. So the mainstay of treatment in relief of an asthma attack are beta-2 receptor agonists. So these stimulate beta-2 receptors, that is the noradrenaline, adrenaline receptors, that are normally responsible for causing bronchodilation. Stimulate these receptors, you get a massive bronchodilation, and that's the first line therapy for asthma. So this is drugs like salbutamol, which you'll probably know as Ventolin. So Ventolin's the brand name, but here we used our generic name, salbutamol. So that's the main treatment for relieving an asthma attack. Historical treatment we'll also mention for its more sort of interesting pharmacology is the xanthine derivatives like the theophylline, not very commonly used these days. And sometimes where the beta-2 agonists are contraindicated, you might see use of anticholinergics, which we first brought up in our drugs affecting the peripheral nervous system lecture. So these inhibit muscarinic receptors, and they cause a slight bronchorelaxation. They're blocking this parasympathetic induced bronchoconstriction by reducing the sort of intrinsic vagal tone from the vagus nerve. Parasympathetic fibres would normally cause a degree of bronchoconstriction as a baseline. So going through these a bit more slowly, we'll start with our beta-2 receptor agonists like salbutamol or Ventolin. These are our relievers during acute attacks, and the relievers need to be short-acting. They need to have a rapid onset of action if you're going to relieve a dangerous, even potentially fatal attack. They stimulate the beta-2 receptors, and that causes a direct bronchodilation. So stimulating beta-2 receptors, bronchodilation. You'll also get a degree of mast cell membrane stabilisation, that is less release of inflammatory mediators or less further release of inflammatory mediators from the mast cells. That was our trigger for all this attack and bronchoconstriction in the first place. We generally give them as inhaled formulations, partly because you get rapid delivery to the lungs. You don't have to wait for absorption from the gut, but also to limit the adverse effects. You want to get the beta receptors in the lungs as much as possible while limiting stimulation of beta receptors elsewhere in the body. You want to open up the airways without putting someone in full-blown fight or flight, basically. That said, you can still get some cardiovascular system stimulation, skeletal muscle tremors, hypokalemia, and irritability or anxiety as well. So this is from stimulating beta receptors elsewhere. Now, the actual molecular mechanism we'll go into here. So the beta-2 receptors on airway smooth muscle cells, you'll find them, they're a G protein coupled receptor. So when stimulated, they activate a G protein, which in turn activates an adenylate cyclase enzyme to create a second messenger, cyclic AMP. And the actions of cyclic AMP include inhibiting calcium channels, less calcium, less muscle contraction. They also activate protein kinases, which in turn can activate potassium channels, leading to cell hyperpolarization. And that hyperpolarization is also going to inhibit muscle contraction. So overall, you get inhibition of actin-myosin interactions and therefore bronchodilation. Now, you don't need to know each of these steps of the molecular actions. The key points that you do need to know is beta-2 receptors get activated, and that leads to bronchodilation. So beta-2 activation, bronchodilation, and that's going to relieve the symptoms of the asthma attack. The inflammation will still be occurring in the lungs, but the airways get opened right up so the person can breathe again. We also have long-acting beta-2 agonists. These are drugs such as salmeterol. These have a much longer, more sustained bronchodilator effect, but they have a slow onset of action. 20 minutes, it's not that slow, but it's too slow to be used in an acute attack. You need to get the person breathing normally as quickly as possible in acute attack. They're also not going to have their maximum effect until about 1 to 4 hours after they're taken. So we call them symptom controllers. They're not truly a preventer because they don't prevent inflammation, but they're also not truly a reliever because they're not going to be useful or fast enough in an acute attack. So they're useful for controlling easily predicted symptoms. So some asthmatics get nocturnal symptoms nightly or early morning exacerbations or get exercise-induced asthma. So where patients know that their asthma is very likely to occur, they can take these beforehand. Not a preventer though, because they don't reduce inflammation or the immune response in the lungs. Now, whether you're using short or long-acting beta-2 receptor agonists, you can get some adverse effects from stimulating other beta-2 receptors around the body. Restlessness, headaches, increased blood flow to the brain, to heart muscle, to skeletal muscles, tachycardia, increased glucose levels, and increased insulin secretion in response to that. So all of that's just from other beta receptor stimulation around the body. By taking it as inhaled formulation, you limit the dose elsewhere while maximising the dose in the lungs. You also get some contraindications for these, so any hypersensitivity obviously, deteriorating chronic obstructive pulmonary disease, and for some of them certain cardiac conditions as well. They're going to have their effects blocked by beta blockers. These are beta receptor agonists, those are beta receptor antagonists. Obviously they'll cancel each other out somewhat. And monoamine oxidase inhibitors will reduce noradrenaline availability and so reduce their effectiveness. So our next asthma drug is theophylline, or it belongs to a class called the xanthine derivatives or methylxanthines. That's the same group of chemicals that caffeine belongs to. So theophylline is these days really a third-line therapy for asthma, rarely used, though it was, we're included here mostly for its historical use. It predates the beta-2 agonists and so has a long history of use for asthma. It's fallen out of favour for asthma though because it's got much more frequent adverse effects than the other bronchodilator reliever medications like the beta-2 agonists. Part of this comes from the fact that it has a very narrow therapeutic index, so just a bit too much and you get too many side effects. Where it's still used a bit more often, though still not as a first-line therapy, these days is for the bronchospasm that you'll see in chronic obstructive pulmonary disease, things like chronic bronchitis and emphysema, and a few cardiac causes of breathing difficulties. So its mechanism of action is it targets the enzyme phosphodiesterase. This is the enzyme that metabolizes cyclic AMP. Remember our beta-2 agonist set off signal transduction that created an increase in cyclic AMP in the smooth muscle cells of the lungs. So this is again leading to increased intracellular levels of cyclic AMP, but rather than by stimulating a receptor that causes cyclic AMP to be created, it's by blocking the enzyme that would normally break down that cyclic AMP. But again, more cyclic AMP, you get smooth muscle relaxation. So this figure here shows that again as well. So we see here that this cyclic AMP that's created by an adenylate cyclase would normally then be able to activate second messenger systems like PKA and so on. And you block that and then you block the phosphodiesterase that would normally break down the cyclic AMP, and you get more cyclic AMP activity leading to things like bronchodilation, decreased pulmonary arterial pressure as well, and increased airway diameter. So it's not quite as specific to the smooth muscle cells of the airways as is the beta-2 agonists. Hence you get the arterial effects as well, and you also get a number of effects within the brain. Some of this is thought to help facilitate the effect of theophylline in asthma, so helping with the central control of respiratory function, but also with the potential for too much neurological stimulation, that at the severest end of too high a dose and adverse effects, there's even been seizures and deaths that have occurred. So basically, though, we get this increase in the concentration of the two main second messengers, cyclic AMP and calcium as well. It's secondary to the effect on cyclic AMP because we're inhibiting phosphodiesterases, the enzyme that normally breaks down cyclic AMP. So the adverse effects are mainly nervous system overstimulation. So most commonly noted are nausea and vomiting, also with insomnia, anxiety, nervousness, epigastric distress and pain, tachycardia as well, particularly risky in young children, and can't be used where you have angina occurring as well, because the myocardial stimulation, increased work of the heart, can bring on an angina attack. Will increase lithium excretion, and things such as macrolide antibiotics can increase theophylline levels. And there's also interactions with St. John's wort which may decrease its efficacy, and even things like black pepper can increase its serum concentration and adverse effects. So with a narrow therapeutic index and a number of interactions, it can be difficult to control theophylline toxicity, hence it's fallen out of favour. The last bronchodilator or reliever medication is the antimuscarinic drugs, or the anticholinergics. So we met these in our drugs affecting the peripheral nervous system. In asthma, they're usually used in inhaled formulations. They're not the most common treatment in asthma. Again, it's almost always beta-2 agonists, but they might be used for chronic asthma where the beta-2 agonists have not been sufficient, or asthma with diminished cardiac reserve, so where for some reason, because of a cardiac condition, you don't want to risk beta agonists stimulating the beta-1 receptors at the heart. The agonists in asthma are quite selective for beta-2 receptors in the lungs, but enough of the dose and you'll still stimulate beta-1 receptors at the heart. So these anticholinergic drugs cause bronchodilation by inhibiting the cholinergic bronchomotor tone, that is, the parasympathetic input that normally causes a baseline degree of constriction in the lungs. Doesn't get as much opening of the airways as the true bronchodilator beta-2 agonists do. You also be blocking vagal reflexes that mediate bronchoconstriction in asthma attacks, so helping in that way. You'll get all of your typical anticholinergic side effects, though to a lesser degree with inhaled formulations, but things like nausea, headache, dizziness, dry mouth. You can get throat irritations and cough, and there has been noted paradoxical bronchoconstriction, so the opposite than anticipated effect, probably from central effects. You wouldn't want to use it if anyone has an atropine sensitivity, or urinary retention, constipation, and certain ocular complications where you don't want to inhibit parasympathetic nervous system function. So this figure shows a couple of those relievers, showing here a postganglionic cholinergic nerve, so a parasympathetic nerve, with acetylcholine being released to act on the muscarinic receptors on the smooth muscle cell. And that's going to contribute to this cholinergic tone, this level of constriction, contributing to increased airway resistance and air trapping. In an asthma attack, which we can see here, you want to either relieve that cholinergic tone by blocking those muscarinic receptors with a muscarinic antagonist, an anticholinergic drug, or stimulate the beta-2 receptors to cause airway dilation and help to relieve this asthma attack symptoms that we can see here, so that you get less airway resistance and less air trapping occurring within the lungs. So this is showing the asthmatic airway, not showing it being relieved. So the actions of the drugs would relieve what you can see here in the image. So